Anyway, welcome to this session, kindly sponsored by Febromed, who have the birth equipment that I'm going to demonstrate on today. The Art of Birth has been running for about 4 to 5 years, and we're really passionate about creating better birth experiences, not just for mothers and babies, because we're realizing now that birth is more than just 24 hours in the labor room. We know that what we do while the baby's in the womb, up until the time the baby is delivered or birthed, will impact that baby long term. This is what genetics and epigenetics is telling us. So we really want to create better birth experiences. I'm here today with Joy Palmer. She will introduce herself, but I'm an obstetrician and gynecologist, trained in London. Very fortunate to have been able to travel around the world and see how they birth in different contexts. So as well as birthing lots of mothers and babies in the UK, I've also been to various parts of Africa, from Kenya to Malawi to Nigeria. And it's been a real eye-opener. I have to mention, once again, Febromed and also the Winston Churchill Memorial Trust, who actually funded me on the traveling fellowship. And this is where I've developed my understanding of physiological birth.
Okay, so my name is Joy Palmer. I'm a practicing midwife based in London, and I trained in London as well. And the reason why I got involved in the Art of Birth project is because I really do believe, as a midwife, there are things that we can actually do to transform our practice so that we're not just task-driven, we're actually knowledgeable doers. So what we want to do in this project is to teach the physiology of the art of birth, in that we know that it will make sure that your confidence in practice is at a greater level than it is right now. We want you to be able to prove what works, what doesn't work. And we want you to be able to feed back to your local community, so those people that you work with. We want you to be advocates in your practice, and we want you to also lead. So really what we want you to do is to be trainers and teachers as well. And the overall thing that we really want to do is to create a physiological birth service for the women that we are looking after.
You can see at the bottom here, we have a hashtag, where's the physiology? And I put that there because, you know, the common catchphrase nowadays, not just for obstetricians, but also midwives, is where's the evidence? Where's the evidence in that? There's a lot of the stuff I'm going to tell you today, there is no evidence. I hope you understand it. It's just physiological common sense. It's how the body works. We don't need to have a big RCT to tell us that this is the right thing to do for mothers and babies, okay? So really, let's change the hashtag from where's the evidence to where's the physiology. And that's where we really start to improve our practice. The Art of Birth basically is saying, let's move away from this two-tier model where we have midwifery on one side, where it's all meant to be normal, technocratic. I'm meant to be here, I'm meant to be all red. Let's move away from all of that and understand it's all about creating good experiences for mothers and babies. It's not about the product of birth. We focus too much on, she had a home birth, she had a vaginal birth, she had a cesarean section birth. That is a product. We really want to understand the process of the experience, and that is physiological. When we think like this, we understand that everything we do in birth is an intervention. Or in other words, it's a creation. We're creating something good or we're creating something bad. It's as simple as that. So let's focus on those things. So Art of Birth basically stands for 3 things: allow, release, and transform. And allow, basically, this means accept what's there. We have a big problem in practice that we see something that's there, we want to ignore it because we think physiologically that shouldn't be happening. Let's ignore the caput, let's ignore the moding, and let's try and do something else because physiologically that's what we want to achieve. With allow, it's accepting, recognizing that something is there and tailoring your approach. Then releasing means letting something go. Let the physiology do its own work. And that's how you're going to transform not just the physiology but the experience of the mother. So I just want you to remember, birth is not just during the labor room. It's 3 weeks from the time the baby's in the mother's womb all the way up until the time the baby's 3 years old. This is the canvas that we are creating. And if we don't understand how wide-ranging birth is, we will never start to really improve the outcomes for these mothers and also for these babies. So with the Art of Birth, we basically say that we're creating a canvas, and there are lots of ways to allow, release, and transform. They all begin with A, R, and T. I'm not going to go through all of this today, but this is a way that we can really get people to start applying what they know in practice, researching and teaching. And there are actually hundreds and thousands of these. And I don't have to prove evidence. This is what people are writing about in the books anyway. I've just put them in this canvas to make it easier. And like I said, everything we do is a creation. So as well as creating positive things, we can also create really negative things. And if you look on, I'm a big fan of Mumsnet, so I go on Mumsnet a lot, but I also go to other places as well. There are lots of other A's, R's, and T's that mothers are complaining about and babies are complaining about. So they're complaining about anxiety, the trauma, the tension, they're being tampered with in practice, when they're giving birth, the ripping that they're having, the regret of having that birth. So these are all A's, R's, and T's that we're also creating in our birth practices. So we need to flip it to the other side and really think about the positive. And I'll just end, before I go into the main reason why we're here today, about why it's so important. We understand it's important for mothers, but we're not really appreciating how important it is for babies. Now, there are lots of studies. A lot of them are European. We're still in Europe, so I suppose that includes us as well. But there are lots of studies, even though they're small studies, but people are taking them seriously, where they're actually saying that, look, birth complications that occur anytime from 3 weeks in the womb up until the age of 3 years old. So a birth complication could be anything. It could be physical trauma, but it could also be psychological trauma. A baby can get psychological trauma from the experience of the mother. If the mother is depressed, the baby can get depressed. The only thing is that the baby can't think about being depressed. It translates those things as feelings. So these birth complications, in addition to having a mother that can't help the baby to understand those experiences, is a big risk factor for adolescent trauma. So self-harm, suicide, aggression. There's so much study out there. So remember, what we're trying to do in birth is so much bigger than what we think. It rarely is setting up or creating that canvas for that child. And these are some of the things that they found in some of the studies. So a relationship between being resuscitated and committing suicide. And even the type of suicide. So asphyxiation at birth, kill yourself by asphyxiation as an adolescent. Mechanical birth trauma, dying by violent mechanical means. Now, I must say that these are smallish studies, but people are repeating them. And especially now that the psychotherapists are now on board and they're going back into people's birth experiences, this is going to become more and more to the forefront. So what we do to try and create a good experience for the baby is so important. And these are just a few more of the others. I think you're going to get videos of this at the end, so you can always go through and look at the slides again. So if this is the art of birth, we need to be able to paint almost. And what we have to paint with is the physiology of the mother, all of the P's that the mother has in her. So we know about the passenger, the powers and the passage, but actually there are other bigger P's out there which are more important. And those P's are really important because they create a system of pressure. And it's pressure which is the big problem we have in our services. If I talk to you about pressure in services now, you can tell me what the problem is in terms of pressure. There's pressure throughout the whole system, but especially pressure for that mother and for that baby within the service. So basically, we need to allow, release, and transform a lot of these P's at 3 levels, at the philosophical level, at the physiological level, and at the practical level. And I always say to people that, look, there's no point doing something practically if it doesn't fit with the philosophy of the mother and the baby. And if you're doing something practically, it has to make physiological sense. If it doesn't make physiological sense, you are going to impact and cause a bad experience for the mother and the baby. So the art of birth really is just about showing how do you allow, release, and transform those P's. But like I said, that's a completely different talk for another day. We're going to really talk about position. This basically is just showing you how allow, releasing, and transforming each of these different levels can help you to understand how you're creating a canvas of care. So you can actually start to reflect on what birth did that mother have and what did I create. So position, which is why we're here today, basically is just about positioning pressure. We need pressure. Remember, nothing in birth is bad. We often say the bed is bad and the birth ball is good. Nothing is bad. It's how you use it. It's how the mother is allowed to use it to paint with her own physiology, which is the most important thing. So position, that we spell with 2 N's, is really about positioning pressure. And I think we need to realize that many of the issues we are facing in birth are all as a result of pressure created in the woman's body. And a lot of you may have heard of the term future midwife. We need to think about what's the future of the midwife. Well, for me, as far as I'm concerned, the future of education, not just for the midwife, but for all birth workers, is to understand that we're dealing with a system of pressure in the woman's body, and our antenatal care, our intrapartum care, and even postpartum care needs to completely change. We need to move away from inviting women just to have their blood taken, and then send them back again, and then try and understand what's happening with that. We need to understand that the best medicine is in that mother's body and in the baby's body. So lots of things such as blood pressure, pain, whether it's SPD or back pain, psychiatric problems, tears, it's all as a result of pressure. And if we understand that, let's try and minimize the pressure that we're creating, but leave just enough so that the baby will birth itself naturally. Then we can move away and get and have less issues. And these are some of the problems that pressure or tension creates. So like I said, I will leave you. I'm happy to discuss this with you at the end or send you an email. So when people often talk to me about tearing of women's bottoms, I find it still really fascinating that about, I think, 9 out of 10 or 8 out of 10 have some degree of tear to their bottoms after birth in the UK. That's about 350,000 women a year. I think it's even more than that. It's really, really significant. And if there's one thing I want you to take away from today is that a tear in a woman's bottom is a pressure issue. It's almost like a pressure ulcer. And with pressure ulcers that take 3 hours to develop, if a woman has a tear in her bottom, it didn't disappear from nowhere. It was something that was developing for 3 hours before it happened. There was something that we were doing that created great amounts of pressure that maybe has accelerated that degree of pressure, and that's the reason why she has torn her bottom. Yeah? So remember, this is only a 1 hour introduction to positions. I'm really going to gloss over things quite quickly, but I'm happy to send more information or come to a position course at the end. And the reason why pressure is so important, on my Winston Churchill Trust, I went to Australia to go and learn how to scan. I wanted to scan mothers after birth because they're trying to ban vaginal birth. Definitely ban forceps, but ban vaginal birth. They think it should be something left to fringe groups. And the reason why they're saying that is, if you look at this is a woman maybe on her back. It's not exactly the angle, but imagine this woman's on her back. This is the urethra, and this is the vagina and the back. This is the vagina and the back passage. Here is your pelvic floor muscle attached to the pubic bone up here. And what they're finding is that a significant number of women, about 3 in 10, sometimes even more, especially if they've had forceps, actually have a rupture of that pelvic floor muscle. And that means that the woman will be back in clinic in a year, sometimes even less than that, prolapse problems, incontinence problems. It is an issue. So why is this happening? I skip through this because this will take some time because I really want to show the videos. Well, why is this happening? Well, let me just take you through our 3 levels of position really quickly. So we've got 3 levels of position. We've got position 1, which is all about antenatal positioning, which is really important. We have position 2, which is about what you have to do intrapartum. And then we have position 3, which is all of the postpartum things you have to do to position the mother so she can recover, but also positioning the baby, and also helping the mother in terms of nutrition. So position 1 basically starts with this idea that, look, women are designed to give birth. We get really tired of this issue of women are not designed to give birth. They are designed to give birth. They have beautiful physiology. It all works. It's all in place. So they are designed to give birth. We know that, yes, when a woman becomes pregnant, she increases her weight, her breasts increase in size, the uterus grows, it shifts her center of gravity forward. So therefore, she's now toppling over the top of her toes. So to balance herself, she moves backwards. And in moving backwards, she develops this lordosis of the spine. All of that for me is beautiful because it just means that the baby has a nice curve to start coming through the inlet. It all works. It all works really, really well. What doesn't work as well are the practicalities of movement. And this is where antenatal care needs to change. So what we don't seem to appreciate is that, look, mothers are designed to give birth, but they are not designed to give birth to the policies and practices that we have in our units at the moment. Yeah? We are not doing anything to help these mothers in the 9 months, I'm sorry to say, as far as I'm concerned. We could be doing more. At the moment, it's left to the yoga teachers. Sometimes they get to physio. The midwife, all birth workers, but especially the midwife, can do a lot more. So we need to be empowered as the future midwife to be able to do more. Because we know that women come into birth with very poor posture. My posture is not the best, but rounded shoulders, they sit all the time, all of their muscles are tight, and let's not forget that the muscles are attached to the pelvis. So you've got the quadriceps at the front, hamstrings at the back. They're all tight muscles, and they pull the pelvis out of whack. This is where it becomes a problem. Some of you would have done spinning babies where they teach you about how to release these muscles. This is extremely important. We need to take that as our practice and start doing something different in our antenatal care to really try and release these muscles. And often, like I said, when we think about the muscles, we only think about the pelvic floor. So remember, if she tips forward, because she's trying to keep herself steady, to try and balance that pelvis, she will grip her bottom. That's what she does. So these pelvic floor muscles are very tight. Now, the problem with muscles being tight is that other muscles become tight as well. So it will affect her other leg muscles. It will affect the psoas muscle. Then on top of that, you now have the problem with the prolonged sitting, the poor posture. All of these things need to be corrected. We need to allow them, but we need to release the tension in them, and then we can transform the pelvis. These are things that we can easily do as birth workers. So these are some of the muscles that we really need to think about. The inner thigh muscles, which are extremely important. If I ask some of you to sit on the floor now, cross-legged, she's got nice, relaxed inner thigh muscles. You can see her there. She can open her legs. I can't open my legs. I was, it's better than it was, but once I realized all of this, I sit down on the floor a lot more than I sit now. Inner thigh muscles are really tight. The outer adductor muscles are tight. The front of the hamstrings are tight. So all of this pushes the pelvis out of whack. So in position, we basically show you where all of these muscles attach, and we show you how to recognize when they're tight, and we show you how to release them. Really simple exercises. It's not something that you need to go and pay hundreds of dollars for. And we're actually working to develop an online resource that mothers can just access really simply, and as midwives, you can empower them. But this is just how the body works. And if it helps mothers, it helps us as well. We're all mothers. And then the other thing that we try and understand really importantly is what happens with the abdomen, which is really important. We don't do any core training for the abdominal muscles, which are really important as well. And if they're weak and they're not working, how do we expect mothers to birth? So this essentially is what we do in position 1. We show you about the muscles and the connective tissue and how to allow, release, and transform them. And another thing that's really important, there's this big drive now to, this concern about mothers' mental health. But what people would seem to lack or seem to understand is that any emotional problem always gets translated into a physical problem. So if the mother has mental health issues, she's going to be tense. She's going to have tense muscles. And so that on top of the physiology and on top of the practicalities of the sitting and the poor posture, that is what causes the problem that we have in our labor ward at the moment. Yeah? It's not the intervention. It's not doctors interfering with induction and all the rest. It's all the things we should be doing antenatally that we need to sort out. So given that 50% of women will come in with some degree of mental health trauma, 50%, and then a good significant number of those women will actually develop mental health issues during pregnancy, we need to be able to allow women to release those emotions, which is normal, and then that will also help the tension as well as the exercises. So just a few tips for you that we can really start telling our mothers today. We need to rearrange our antenatal clinics. If possible, get women sitting on the floor. If they need to sit on the chair, let them sit with the chair in front of them. It forces them to lean forward. It makes their pelvis nice and neutral. It stretches the muscles. Get them walking more. Minimize sitting as much as possible. Get them to stretch and release and do lots of exercises. And don't rely on relaxing. These muscles are tight. They need to be released. If they're not released, the baby's going to be in a malposition and then you're going to be struggling during the birth. Don't rely on relaxing. Relaxing is good for all of the ligaments. It doesn't do anything for tight muscles. The muscles need to be released separately. So
don't be afraid.
This is a video from a unit I went to in Norway, and they're just showing what they do to release some of the muscles. They do this a lot antenatally, and this is something that mothers can do themselves naturally. But also, this is something you can do during the birth. As a routine, most of my mothers in Kenya, I tend to make them, all of them do this at the beginning of the labor and at the end, or at least regularly every 3 hours. Rather than doing the VE, get them to stretch the muscle on each side. So this is what we teach in position. It's a very simple thing to do. Most of you in this room would have seen women do this naturally themselves anyway, when they're moving around and they're trying to stretch themselves on the bed. They're trying to release those muscles following their instinct. But rather than prescribing syntocinon on the chart, can we not prescribe a release? It's a very simple thing to do. And you're working with the mother's physiology.
Yeah, and then you have to do it on the opposite side as well.
Can you feel that?
And like I said, we also have position 3, which is postpartum. But I really want to focus today on position 2, which is really about what can we do intrapartum. Because for me, that's the most pressing thing at the moment.
Okay, so just looking at this picture here, what is it telling us? Can anybody just very quickly tell us what it's telling us? Okay, so what's happening here is this baby's just been delivered, and what have we got here? We've got caput, yes? Okay, so this baby is telling us something, but what have we actually done with that information? What is that baby telling us? It's telling us about its position. It's also telling us that somewhere in the physiology, in those ligaments and the tissues in the pelvis, that there's some tightness, and that is what has caused this caput and some moulding. So when we're at work and we actually do a vaginal examination, what do we do after our vaginal examinations? We document. Okay, we pass that information on, we escalate the information on to the coordinator, we write it up on the board, possibly, and we make sure that the registrar who's on the ward is aware of what's going on. But what have we actually done with this information? Do you not think that we should be using that information maybe to change the woman's position, to release that tightness that is causing that caput, that's making that labour much longer? Do we actually do that in practice? Just think about your practice right now. What do we actually do in practice? Our documentation is on point, okay? But we document that there is caput, but the baby is actually telling us that there is some tightness, the state of the tissues and the ligaments in the mother's pelvis is that it's causing caput. So there is things that we can actually do with that information. So just moving on, right, so this is why we're actually here. We're here because of position, and this is really a taster. And just using position, if I just quickly go through this, we do a palpation, we check what the cervical os is saying. We check where the suture is, if it's in line. We check if there's tissue and swelling, caput. We check the position of the presenting part in relation to the ischial spines. We check if there's any moulding. And we want to know what the baby does when the mother bears down. And we also need to remember the neonatal condition. Is there meconium, for example? So what we need to do in our practice is to make sure that we're using a systematic way of using the information when we do a vaginal examination, rather than just documenting the information and not really knowing what we're doing with that information. We need to use that systematic way of using that information in order to listen to what the baby is actually telling us. For example, if there is caput. And so therefore, it's important that we actually take on board this information. Babies are not just the passengers, they are the major players in the labour.
Okay, so with position basically is the baby's philosophy. So I said that we're trying to release these major P's: philosophy, then the practicality and the physiology that makes sense. So if the baby is speaking to us and giving us a philosophy, look, I need some help here, I'm a bit tight on this side, we should do more than just document. Although, of course, our practice is more than that. We do try to reposition the mother, but do we reposition in a practical way that makes physiological sense? We put all mothers maybe on the left side or on the right side, but we don't tailor it to what that baby actually needs. And that's what the physiology of the baby is, the philosophy of the baby is telling us. The degree of caput, where the caput is, and the degree of molding actually tells you where the degree of tightness is. And there are specific things you can do in your practice practically to try and help that. So remember, do a VE or do some kind of assessment, either looking at the mother and say, look, that baby is telling me something. What's the baby telling me? Maybe everything's hunky-dory, it's fine. But if it's not fine, what do I practically need to do to help that baby? Now, I haven't got time to go through all of the different steps. In position, what we do, we show you what to do when you have an anterior lip and what side it's on and what kind of techniques you can do. And each of these letters, position, also stand for practical things that you can do with the mother's body. Because remember, it's not just about making the pelvis move. Movement is not about just making her move 24/7. It's about making more parts of the body move. But she doesn't have to move 24/7. So, like I said, position stands for lots of things you can do with the mother's body. But there are 3 things I just want to focus on today. There are only 3 things that change the inside of that pelvis. And it's the inside of the pelvis you want to change. 3 things on the mother's body. It's the spine, the mother's leg, and the mother's hip. And if you do 3 things with those 3 things, this is when you can really start to affect change for that baby if the baby needs it. Now, if the mother is going along completely fine, leave her alone. But of course, when you're doing all of those V's that we have to do, and you find there is a problem, let's start being more specific. So let's focus on just these 3 things today. And I have Febromed's equipment that I will use to demonstrate that. The spine, the thigh, and the os coxae, or the hip. Those are the only 3 things that would change the capacity of the pelvis. You can do all other things, it's just for comfort. All of this rocking around and everything, that's fine, but you're not changing the internal capacity. And this is very important to understand because often we say, yes, the pelvis, if you have it upright, it will increase the capacity by 30%. What you should ask yourself is 30% of what? 30% of what? Because the pelvis only moves 3 millimeters at a time. If she's pregnant, with the relaxing, you might get maybe 6 millimeters at the back, around the sacrum. But 30% or 6 millimeters isn't that much. It is really a tight squeeze, but women do it all the time without injury. So we need to really make the most of the movements of these 3 practical things, the spine, the thigh, and the hip. That's where you start to get the most change in your practice. And then you start to see that physiologically you're doing something. So in the position course, we show you that when you're moving the spine, you're actually abducting or adducting something. And then when you're moving the thigh, you're actually rotating something. So we show you what's rotating. And when you're moving the hip, you're actually tilting or tucking something. If you can actually achieve all 3 of these things at once, that is art. It spells art. That's the art of birth. Yeah? So hopefully we'll have time to show you some of the videos to demonstrate what we're doing. But who agrees with this, that the sacrum is the most important bone to open the pelvis during birth? Show of hands. Is it the most important? Is it an important bone? Is it the most important? Show of hands. Who agrees? Who doesn't agree? Got a few abstainers. Okay. The sacrum is extremely important. It is a really important bone, but let me just tell you one thing. The sacrum can only move backwards and forwards. Yeah? It can only move backwards and forwards. It can move backwards, which is called nutation, or a tilt. It moves backwards and slightly downwards, taking the coccyx with it, or it can move forward. So that's a tuck, where the mother tucks underneath, okay? What is more important than the sacrum, for me, are the hip bones, the innominate bones, the ilium, yeah? Because they can move 3-dimensionally. They can do all those 3 movements I told you about. They can abduct or adduct. They can rotate internally or externally. And they can also tilt and tuck. And what's also important is that when you get the movement here right, it then either squeezes the sacrum or releases the sacrum. So what you do at the hip and the thigh that affects the hip is the most important thing. And there you get to the sacrum. So yes, by all means, make sure the sacrum is free. But there's no point freeing the sacrum if you've restricted these bones here, which is what we often do in practice. Now, another question for you. What's the correct position of the legs for pushing? Can we have a show of hands? No abstainers this time. Yeah? Who believes that this is the correct position for pushing of the legs? Hand up. This one? So what do we do? She doesn't open her legs at all? Okay, so how does she open her legs? Squatting. So someone said squatting. Anything else? On her side. Okay, but even if she's on her side, her legs are going to be in some kind of position. Let's just say that these are the 2 main positions we see during birth. Whether she's on her side, whether she's squatting, what's the correct position of the legs? This or this? This. So we agree with this. Can we put our hands up? Yeah? Okay. I want you to watch this and then tell me what you think. So we have a woman, she has flexed her legs. We normally do this in birth. This is good. Flex the legs. So we have a woman that's flexed her legs. This is good. It's normal to flex your legs. It opens the pelvis. Physiologically, we show you what bones are moving, which is very important. We have abducted the hips, which also is very good as well. But we've also, in this frog position, externally rotated the hips. And external rotation actually closes down the outlet. Yeah? Now, I can tell you, if you go to YouTube, you go to all of the photos they have online, all of the posters, when it comes to pushing, women are always doing this, always. It might be a version of this, or it might be slightly like this, but they always have external rotation of the legs in pushing. And this is a big problem because it's not just the bones here, we also have the pelvic floor that needs to relax. And if you've closed the outlet by doing this, you have a closed pelvic floor, which is tense, which can't hold the amount of blood that it needs to hold, so the blood goes somewhere else, her blood pressure goes up. We've all seen that in second stage, blood pressure goes up. Oh, she's got PIH. She hasn't got PIH, she's just got a problem with pressure because we've created and closed down the whole of that outlet. So if there's one thing I want you to take away today is please leave the legs alone. And I don't know how many of you know Pink Floyd's song, and we're going to sing it as we show some of the videos. But whenever you see the legs being forced open, it's not just lithotomy that's the problem. It can be the doctor's hip, the midwife's hip, holding those legs open. I just want you to sing, please, doctor, leave those legs alone. Yeah? Leave the legs alone. I'll show you some videos where the woman will naturally bring her legs closed. And what do we do? Open your legs. Open your legs. Give the woman some room. Yeah? This is what creates shoulder dystocia. This is why we get shoulder dystocia with small babies, not even more than 3 kilos. Yeah? So she's pushing all wrong on her back, which is not good. The sacrum is blocked, which is a big problem. What type of rotation of the legs do we have? Internal or external? External rotation. Yeah? Can anyone sing with me? Point to the lady and tell her, please, leave those legs alone. Yeah? And then see what we're doing with the other leg? Well-meaning, but we've completely trapped that baby.
Nice. Oh yeah, that's it. That's it. That's it. That's it almost.
The crown.
Okay, okay.
Now it should not be that tight. Yeah? And we've seen it all the time. You deliver the baby, then there's a big clunk to get the baby out. And it's all because of this. Yeah?
Deep breath. Push. It's almost all the way out, Sarah. Almost all the way. Almost. Oh my God.
Keep pushing.
Push.
Okay, I'm just going to check for a cord.
Push.
I know.
Okay, so just
Come on, push. Ready? Shoulders
Again.
out.
Go again.
look at where the woman's legs are.
No cord. Come on. Come on. Bear down and push.
Push.
Come on, push.
Push. Come on, baby.
Come on.
Push.
Push.
Come on. So close. Heads out.
Come on.
Push.
There you go. Come on. Bear
We
down
still
and
do
push.
this in practice.
Come on.
The woman's legs open.
Keep going.
Leave those legs alone.
Push with your
Use
mouth.
your
Close your
energy.
mouth. Close your
Push
mouth
with
and
your
push.
mouth. Yes.
Close
Come
your
on.
mouth and
Push. Come on.
Push. Push.
There you
we
go.
go. There we go.
There
Push.
you go,
Push.
sweetie.
Push. There's a baby. There's a baby.
Okay, so
There's a baby.
Got time.
what do you all think
17.
about that
Come
birth?
on, little.
What did you think about that birth?
Leave those legs alone. Yeah?
Okay, so what are we going to say in practice? Hey,
Legs,
doctor,
let's sing.
leave those legs alone. Say it with me.
Hey, midwife.
Hey, Midwife, leave those legs alone.
So remember, it's not just the bony outlet you've closed. She also has a tense pelvic floor. And that's the reason why you get that ripping away of that tissue. The pelvic floor is tight. The outlet is tight. This is not a good experience for that baby. This baby will come out, at best, maybe claustrophobic, having feelings of, feeling trapped in a tight space. It seems really crazy, but these are the children that will go on if they don't have a good maternal understanding of what's happened to help them to relate that experience. These are the babies that will then go on to have problems later on. And it is very common. Do we not see this in practice? Does it happen or it doesn't happen? It happens. Now, this is not brilliant, of course. This is, not the upright birth that we need. Now, I'll explain to you why the upright birth is so important in relieving pressure. But this is just another video just to demonstrate to you how common this practice is and the kind of things that we will tell women to do as well. So listen to the doctor.
Open the give birth. Open the give birth. Open your legs to give birth. Don't squeeze,
And what is she doing naturally with her legs? Yeah, do we not see this in practice? We see this a lot. And what do? Open the legs. Yeah? The baby went in with your legs open. Open your legs so it can come out. Yeah?
Wait. Open the give birth. Don't squeeze, Try again. 1, 2, 3. Open your legs to give birth. Don't squeeze the baby.
The mother instinctively knows what to do, even in that terrible position on her back.
One.
Yeah?
Put your leg properly. Put your leg properly.
Pull and push it. You must pull that.
Okay, backside put down first. Put down your backside. Rest. Rest your backside. Rest. Try to push. 1, 2, 3. Strong push. Go. Good. Good. Correct. Correct. Yes.
Do we not normally say to the woman, give baby room? I've heard myself saying it. Give baby some room.
Wait first. Don't do that. You put down. Okay.
Basically, this is all just very, very bite-sized. We haven't got time to go into things in great detail. I just want to give you a few practical tips that can help in your practice today as we go back to work. So the key thing is the legs. Make sure the legs, depending on the type of birth, I think the thing that's really important to understand, and physiologically we explain this, is that internal rotation is good for the outlets. Yeah? But it closes down the inlet. Yeah? External rotation of the legs, abduct the legs and externally rotate the legs, closes down the outlet, but actually opens the inlet. So would there be times in birth where you'd want the inlet to be more open? Yeah? So this is what I keep talking to you about. That it's very important that we understand what we're doing at each stage of the birth. Take the baby's philosophy, that VE or that assessment, and use it to do things that make sense for that stage of labor, rather than what we do at the moment where you look at all of the birth positioning posters and all the legs are so widely open. I get really scared. They're delivering all of the posters I've seen so far. All of the legs are open. And if there's one thing we can do to change our practice, is that. The other thing that's really important is that pelvic floor. It doesn't just release itself, but one quick way to release it is deep breathing. And these are things that we need to teach women antenatally. The hypnobirthers have it down pat. Teach you deep breathing, because if you breathe to the point where you can actually take a deep breath in and blow out your tummy, you actually automatically relax that pelvic floor at the same time. Yeah? But then the other thing that happens as the diaphragm goes up and the pelvic floor goes up, the abdominal wall, especially the transversus abdominis, which is really important, actually starts to come in and massages the baby. So there's several things happening. You're actually relaxing the pelvic floor, but you're also getting that uterus into a really good angle for that baby to come down. So it's timing your pushing, if you want her to push, or the contraction with her breathing. It's extremely important. So that's something that we teach. Lying on the back is very bad. You can see, can you see her hands?
See what the midwife is doing? The woman is instinctively trying to close her legs. And she's actually been slapped out of the way. She's been positioned now as well. But doesn't it show you that women are naturally doing these things anyway, but we are telling them to do something that's quite unnatural? Just think about your practice, what we're telling women to do and what their bodies are actually trying to do. Think about those deliveries that you've had where you thought, oh, everything went fine, and the woman still ended up with a very large second-degree tear. She's still trying to close her legs down.
She even lifted her leg off the bed, which is what we teach in position asymmetrical positioning, where you're keeping one side of the pelvis free, but you're actually making space on the other side of the pelvis, which is very important. Women do these things all the time, but we clamp it down because we want everything to be nice and symmetrical and open. Yeah? Anyway, it's a bit traumatic, so I'm not going to continue with that, but this is another tip.
Okay, so as we've said earlier on, this is really a taster, and I just want you to look at this picture here, or this diagram, I should say. So the baby is in what position? Is the baby in an OP position? ROP position, yes? Do you agree with me? Okay, so which side should the mother be on? Which side should we put her to lie which side should we lie her on? If we were going to do that, what side do you think would be the optimal side to put her on? Should I put her on her right side or on her left side? On her left side. Okay, so who thinks that she should be on her right side? Hands up. Very quickly, just hands up. Hands right up in the air. Okay, got a few not too sure hands. Who thinks that she should be on her left side? Hands up. Okay, so the denominator is here. This is the occiput. Okay, so let's just move that along. So we've got the woman now on her right side. Okay, so when we put her on her right side, make sure this is okay. Yeah, we put her on her right side. The forces of gravity actually come down and pull the pressure of the occiput, which is the heavier denominator, downwards. So that actually helps the baby to go into an OA position. So there's a pull of pressure downwards, as you can see. Can you see that? Okay, so actually putting the woman on her right side would actually help the baby to go into a much more optimal position for birth. So what do we normally do in practice, though? Do we not just put up some Cinto, or we turn up the Cinto? Do we not? Am I right? Okay, just think about these things in practice. So the intervention could just be putting the woman on her right side, rather than turning up the Cinto, or even starting Cinto. Okay, so the woman here is on her left side. Okay, the pulling down of the pressure on the heavier denominator. Can't do this. Okay. Now that would not help at all, because we'd still be in the OP position. Okay. Sorry.
Okay, so another practical tip for you, always make sure wherever the occiput is, that's the side that you want the mother to lie on. Yeah, it's very important. If she's on the right occiput posterior, you want her to be on the right side because gravity will pull it down. If you make a right occiput posterior on the left side, all you're going to do is pull that baby down into an OP. Yeah. So these are the things that I say. Think about philosophy of the baby, translate it into practicality that makes physiological sense. Someone here mentioned squatting. Squatting is really good. Unfortunately, we're not a culture that squats. I can't squat. If you go to Africa, India, they squat all the time. It's easier for them. In the UK, because we're not used to squatting, as soon as we try to go very low, rather than having this, where we actually have a nice curve of the spine, ideally for the outlet to be open, you want the curve of the spine to be open. Yeah. So we've spoken about the thighs and how that can tell you if the outlet's open. The curve of the spine can also tell if the outlet's open. If you have a nice lumbar curve, that tells you that you've actually got sacral tilt. Everything is completely open down at the bottom. But most mothers, as soon as they attempt to go down, they actually get a sacral tuck. So they do this. So they can't get their foot on the floor because the muscles are so tight. We haven't released them antenatally, which is a big problem. And then on top of that, the pelvis tilts under. So we get a mother squatting down, if she can get down as far as she can, but she's closed the outlet, which is a big problem. Yeah. So supported squatting and not going down so far is the best. And this is why having equipment like this is good, because it's like squatting, but almost not squatting. It's low enough. It's not as high as a delivery bed, but you are low enough that you can maintain that curve in your spine. Your sacrum is nice and free. You should be sitting on the edge of your seat. That's more likely to make your pelvis nice and neutral. And then that basically helps the pelvis to open like this. So I wouldn't advise women to squat unless they're used to squatting, because you're going to cause a lot of damage, close the outlet, close the pelvic floor, horrible perineal tears and pressure. The other problem with squatting, and if you think about this picture, it's the same picture with the legs as well. You can think about the woman being in this position, not just squatting, but even on her back. We put women on the back like this all the time. The problem with this is we create great angles of pressure. So we've got this horrible angle here going through the spine. Having a curved spine in birth, especially when she's going to push, is not good. It creates great amounts of pressure up here. When you have great amounts of pressure in your abdomen, your pelvis then becomes fixed. So even if you're able to internally rotate the legs, you can't move the pelvis as much, even if you've internally rotated the legs. So it's very important that we free the pressure up here. We try to avoid flexing the legs more than 90 degrees. So McRoberts, I don't really agree with, and I think it causes a lot of problems anyway, but we should not flex the legs more than 90 degrees. So by 90 degrees, I mean a woman may be flat on the bed, her legs straight in front of her, this is 0 degrees. Flex maybe to 90 degrees. By the time your hip goes more than 90 degrees, you're pressing on the ligaments here, the inguinal ligament and the nerves. Lots of women get out of bed and they collapse, because we've damaged that nerve there, we've caused the palsy. So we don't want to have great hip flexion, that's great pressure. We don't want to have great pressure at the knee, and we definitely don't want to have great pressure in the chest, especially if she's not breathing properly and she's doing that horrible purple pushing where she's holding her breath, she's not ready, releasing the pelvic floor, got greater degrees of pressure, and then it becomes a problem. And then this is a common thing you do with squatting as well. Squatting, even if she could get all the way down, she couldn't internally rotate her legs anyway. Why? Yeah, her stomach is there, yeah? And this is the reason why I have a big problem with McRoberts, because as much as we say, yes, we flex the woman's legs onto her tummy, we don't, because the tummy is there. So what do we tend to do? Externally rotate, and we close things down, yeah? So it's very important that we really start thinking about the equipment that we have. And this is the reason why I'm a big fan, you think it's quite surprising as an obstetrician, I should be so passionate about this, of hanging. I think hanging is so important because we focus so much on just that part of the pelvis, but all of the woman's body is birthing. And we definitely need to release the tight muscles up here as well. It's very important. When you hang, and you get the spine right, and you get the thighs and the hips right, you also get the pressure right on top, which is really good as well. So hanging is extremely important. And there's so many different ways that you can hang to try and improve pressure. But there are a few tips I want to talk to you about when it comes to hanging, because with anything, there's always a way. This is medical equipment. And if there's one thing that I'm really keen to we're campaigning to happen, as well as stopping that horrible opening the legs during birth, it's ensuring that position is seen as important as learning shoulder dystocia skills and drills. I don't understand why positioning is not mandatory. I don't understand why it shouldn't be a regular update. It's so important, because remember, everything you do, you create is an intervention, and you're creating something. So you need to learn how to hang, which is very important. So the thing that's really important, these are just a few tips here. You don't want her elbows to be too straight, because she's going to damage her ligaments. It's really important. So what I like about this is the fact that you can knot in various places, so you can ensure that it's the right length for the mother, which is really important. You can get her to hang. When she hangs like this, she's not having to squat as much. It's almost like having a squat, but not squatting. She can actually change her legs depending on the stage of birth, whether it's external or internal. Instinctually, she will know what to do. But some women are so petrified that then you have to guide her and let her know what needs to go on. You want to make sure that the shoulders and the ribs are down, because one of the mistakes that we make whenever we try to either straighten ourselves or we hang is that we tend to try and go backwards. And when we go backwards, we actually create pressure in the system. Is it finished? We actually create pressure within the system, which can be a big problem. Is Monique around, the midwife from Febromed? Do you want to come and demonstrate?
What you're actually wanting to do is to relax your pelvic floor. I mean, we all know, we've heard it before, haven't we? Push like you need a poo, you know. And you're actually causing a lot of tension and pressure in the pelvic floor area if you're doing that. So if you're actually hanging and you're holding on, all the pressure would be up here more than down here, and this will then become relaxed. And that's what you need, a relaxed pelvic floor.
So you need equipment. How many of you have swings in your hospital? How many of you have this Febromed equipment, or how many of you have swings? Do you use it regularly? Is it something that women are used to using, or why are they not using it? Why are they not hanging and swinging as much as they should do? Why is that? It's training. It's the understanding of the physiology. Who needs to understand the physiology more than anybody? Apart from the mothers, who needs to understand? The midwives, yeah, the midwife. You know, if you truly want to advocate in practice, understanding that physiology moves you away from being airy-fairy midwives where it's, a gentle birth, a positive birth. When you start talking in physiological terms, people start to take you more seriously. So the equipment is so important. There are many ways that you can hang, but for me, I think hanging is the most important thing. When I go back to Kenya to do my clinical study tours, one of the things that I'm going to introduce, I think it will make such a big difference. The other thing that's really important is try not to swing that much, because when you swing a lot, sometimes that can create great amounts of pressure as well, especially if she's not releasing the pelvic floor. So you don't want to swing that much. And another thing that's really important is we often talk about position and movement. People seem to misunderstand what movement means. They think it means the woman should be on her feet for 24 hours, moving around. Nobody can do that, especially if you're giving birth. You need time to rest. The key thing is to make sure that the woman's body is free to move three-dimensionally, so that the baby, who Joy has said is the major player, can actually do its work and actually start moving those bones around. And the other reason why hanging is so important is what you find is that if you don't allow a woman to hang, she would tend to hang her head forward. Hanging the head forward is a big problem for so many different reasons. It creates a lot of pressure on the spine. Too much pressure is not good, because it creates tension on all of those muscles, so all of the muscles stop working. It stretches the brainstem by about 7 centimeters, and that's a big problem because it can reduce the amount of endorphins that you release, and that makes you more sensitive to pain. So when you're hanging, you tend not to have your head forward as much. So you can actually have a nice straight spine. So remember I said there are only 3 things that change the internal capacity of the pelvis. The spine, what's the other thing? Hip and the thigh, yeah? So, and the other reason why hanging is also very good is that it actually helps to increase the respiratory capacity by about 30%, which is very important because you want the diaphragm to go down, so the pelvic floor will go down. So when you get her to hang, let's say this is a woman who antenatally has not done any of the exercises in position 1. All of her, because it's not just the muscles down here that are a problem, even the muscles in the chest can be a problem as well. If you haven't relaxed and released the muscles in the chest, that can also be a problem as well. So you get mothers coming in with tight muscles everywhere. Hanging actually helps them to release that tension. So I just want to talk quickly about this campaign, and we have a few cards here that you can take away with you. But this is our campaign, Legs Free Birth. I told you one of the theme songs we have, which is Leave Those Legs Alone. I think Joy has another song.
Free those legs and the baby will follow.
And what's quite funny, it's quite a creative campaign. I spoke to one of my other friends, an obstetrician, and he said, oh, you can actually use ain't no baby when she's open. All the muscles are in the way. Yeah. But either way, to take it seriously, this is a campaign that we're taking really seriously. If we can only just change this in our practice, this simple change of making sure that the mother's legs are internally rotated and even starting to hang can actually reduce intervention and trauma by at least 30%. Do you want to give us some idea of why you think it might reduce trauma?
Well, I'm just sort of thinking about the number of deliveries that I have done that I feel that have gone really well, and then the woman has had sustained a birth trauma. And it's just about looking at my practice rather than being someone who's task-driven, being someone who's actually a knowledgeable doer. So this is why this really, it's a campaign that I really feel quite strongly about, and I'm just hoping that a lot of the midwives, a lot of my colleagues do get on board as well. Just think about the woman that you have who instinctively goes on her side in labour. She goes on her left side in labour, and she keeps on telling you that she can feel pressure. Just think about her legs, her knees are together, and what is opening up? The outlet is opening up, and that allows the descent to take place. Think about it. What happens when a woman is like this? Literally, she's shutting down the pelvis. Just think about the things that we do in labour with women. When we say to the women, oh, give baby some room, and we ask women to just extend their legs. But when they're on their side and their knees are together and that descent is taking place. Also, another thing I just want to leave with you as well is when there's an anterior lip, what do we tell women to do? What do we tell them to do? Can't hear you. Do we not tell them to go, not to push, obviously? We also tell them to go on their left lateral. Do we tell them to do that? Just sort of think about the physiology, what's happening, okay? Sometimes we're doing things and we don't actually know why we're doing it, but there is something going on that's allowing that presenting part to descend even further. And one of the things that is definitely happening is that pelvic outlet is being opened up.
So it's all about the physiology, and this is what we're trying to teach in position. So, like I said, today I've just focused a lot on the physiological techniques. What you now need to learn is when I'm squatting, when I'm lunging, when I'm standing, what position does the baby have to be? What's the philosophy of the baby? And what would be the best standing position for her? Now, if she's doing it by herself, I'm not advocating that we start interfering. Leave her alone. But if you feel with all the VAs that you're doing, she's not progressing on the partogram, there is a problem, there are little tweaks that you can do to support her physiology. So she paints with her own physiology. Anytime you do anything that doesn't involve the woman's physiology, you're just courting trauma. It will be a problem. So having birthing equipment that can help you with that is good. Now, many people will tell you that the floor is the best equipment you can ever have. Second to the floor is having equipment which is as low to the floor as possible. We keep talking about gravity. But remember, gravity is coming from the ground, and the higher up you have the woman, the more likelihood there is that you're going to impede gravity, touching that occiput and bringing that occiput to where you need it to be. So it's very important that we have equipment that will support us, that will support the woman into an upright position. Upright position is not just about having the woman upright, it's about making sure the thigh is right, the hip is right, the spine is right for that stage of birth. And it's reducing pressure. And the best way to reduce pressure, you can do all of the sitting in the bed, and she can be on all fours, but she can sometimes have great degrees of pressure. What can relieve pressure is being able to hang in a really low position without fully squatting, because she can't squat because of her back. She's not used to squatting. So I'll leave you with that. We're going to be here for the whole day to sort of demonstrate the equipment. I think Febromed have their equipment in various hospitals around the UK. We're actually starting to take applications for position courses, which are going to be free or heavily subsidized every 3 to 4 weeks. And we're looking for people who want to come as a team to learn how to create better positions in their practice, because really it's going to be a team effort. There's no point doing fantastic work, you hand over the woman because there's no continuity of care, it all becomes undone. So we really want to teach people these techniques so that they can start to use it to reflect teach in their practice. And this is, some of the things that we teach you with position. We have this really simple, it's almost like a birth calculator, but it's a position calculator, and it helps you to work out, can you transform the inlet, and what are you transforming, depending on the position that she's in, whether she's on the birth stool, or whether she's lying on her side. We have lots of these little cards, and I have some cards here which you can take. But this is what we use to teach the physiology, to make it, to make it really, really simple to understand. Remember, everything you do is an intervention. You're creating something else. To really understand it, you have to understand that, if I get her on her back or she has pain, what is that releasing on the outside and what is that transforming? So you then take the next card like dominoes and you start to create what we call a canvas of care. So it becomes very easy to really understand the physiology and to even use it to teach your students or to teach others, which I think is the key thing. And more importantly, please teach the doctors, because we don't know physiology. Yeah? So you can use this to really advocate. Don't talk in emotional, sensitive terms. I keep talking that in maternity research we have a problem. We're too sensitive, we are not specific enough. If you really want to change practice, it has to be physiological. It has to be, I want to internally rotate the thighs, and I want her to hang because it's reducing pressure on the transversus abdominis, and it's actually making the ilia externally rotate and abduct. You want to talk like that, and it's very simple to understand, and that's what we're aiming to do with the art of birth. So like I said, we have a few of these cards. Got a few samples that you can use with different positions and showing you what happens. And then you can get the next card, and it basically starts to show you that cascade of care, or the canvas of care, as we call it. Just a few other tips that we will end on. Please don't get women to spread their legs further than hip width apart, please, especially if they've got SPD. But any woman shouldn't have her legs like this. You are courting trouble with the pubic symphysis, whether she's got SPD or not. But especially SPD, don't spread the legs further than, no woman should have her legs further than hip width apart. It's cruel. Try to avoid extreme hip flexion more than 90 degrees. So any hip that goes beyond this, you're going to be pressing on the nerve, the femoral nerve, the inguinal nerve, and you'll have problems. Make sure the vajayjay is visible, or invisible, I should say. So what do I mean? I mean, you shouldn't be able to see the vagina. Anytime you can see the vagina when she's sitting down, whether she's on the ball, whether she's on the stool, anytime you can see that vagina looking at you, you know that she's tucked her pelvis. Yeah, that's another simple tip. So if she's on the ball, not that I'm going to be showing you the vajayjay here, but you can imagine, if she's on the ball, you want to make sure that you can imagine her vagina, the slit of the vagina, the opening of the vagina is parallel to the floor. You shouldn't be able to see it. Then that suggests to you that she's neutral. If you were sitting on your chairs now, I would suggest to you always sit at the edge of your seat. Naturally, it makes you go into neutral. Yeah? So you shouldn't be able to see the vagina. Another way to make sure that she's not tucked her pelvis when she's pushing is to make sure you can see at least 3 centimeters of the groove of the buttocks, because that means that you've got the coccyx free. Don't cross the legs. I know we often say, women, don't cross the legs. We're worried about blood clots, but more importantly, is tightening of those inner thigh muscles, which is a big problem. I've spoken to you about sitting on the edge of the seat. And then trying to adjust. That's movement. Movement is adjustment. Yeah, trying to adjust every 30 minutes to give the baby room to navigate down the pelvis. So Joy spoke to you about mother, ROP, you've turned her to the right, or maybe you've got her to lunge to the right. Because remember, any intervention you do, you want to do the intervention on the side where the occiput is, because you want to give that occiput more room. So if the philosophy of the baby is ROP, lots of caput, it's all rotated to the right, that's where you want your intervention. That's where you want your asymmetry. So when she's on the bed or she's on the chair, you want to internally rotate to open the outlet or externally rotate. And this is just basically talking about the Academy of P's and Threes that we have going on as well. This is to teach people the wider concept of there's an art to birth. Everything we do is a creation or an intervention. It's not about just learning one way to do things. It's not about the product. It's not about, did she have a home birth? Did she have a normal birth? Did she have a physiological birth experience that didn't traumatize that baby so it doesn't end up killing itself at 16? I know it sounds really crazy, but the research is there. It all comes from birth. People realize that. It all comes from what we do at birth. So I think as doctors, for me, it's transformed my practice. Now I realize the FBS and the instrumental delivery and all the things I do, the long-term impact it has on that baby, it's really made me change my practice. I always think about the experience of the baby. What has that baby experienced? You can look at the baby's face and it will tell you, was it a good experience or a bad experience? If it was a bad experience, what should you do? You want to help that mother to understand this baby didn't have a good experience, so she can help that baby to understand the experience, and then hopefully we'll not have those bad outcomes. But because mothers don't know the baby had a bad experience and the baby can't talk, the baby takes it into its DNA and it becomes that canvas that it uses to understand the map of the world. So please join us on the Art of Birth project. There are various things that we do. Like I said, we've got the cards, we've got the position course. I'm also doing a clinical study tour to Africa, again to Kenya. So I've gone to Pumwani, where they have 100 births a day with 3 midwives on shift. And that's where you basically just get to see everything. No epidurals in sight. So that's where you can really learn the physiological births. If anyone's interested in that, please let me know. And is there anything else you want to say, Joy?
Just to take away what we've been trying to say to you about the positioning of the legs. And if you even try and do it yourself, I don't know if those of you who are here just want to stand up and just put your knees together and just sort of think about what your pelvis is doing. If you stand up, put your knees together, what's your pelvis doing? Okay, now put your legs apart. And what is your pelvis doing now? Think about underneath your pelvis, what's happening. And that is what's happening to women in their birth experience. Okay. Thank you for listening.
Thank you very much, everyone. Please don't all rush to the front. There's expensive equipment.